and I'd like to welcome everybody to today's webinar entitled Antihypertensive Deprescribing in Nursing Home Residents, a Target Trial Emulation. And this webinar is sponsored by the U.S. Deprescribing Research Network with funding from the National Institute on Aging. My name is Ken Bookvar, and I'm hosting from the University of Alabama at Birmingham. A few technical details. We've placed phone lines on mute. And so unless you're logged in as a panelist, your line is muted, but we do welcome and encourage audience participation using the Q&A feature of the application of Zoom. So if you would like to submit a question or interact, a discussion point, please click on Q&A at the bottom and type your questions into the box. You can make your question anonymous by checking the anonymous box before sending. And we will have time at the end during the final 15 to 20 minutes of the webinar for question and answer and discussion. Also, please answer our evaluation email after the webinar is over. If during the webinar you have any technical or logistical questions, please submit those using the chat box to one of our co-hosts, Gabby Schiller, to chat privately, and make sure your name is visible so that they can help you troubleshoot. Also, thanks to our staff supporting this, Vanessa Duodu at the University of Massachusetts, Jonathan Norton at Johns Hopkins, and Gabby Schiller at Mount Sinai behind the scenes to make these webinars possible. So let me introduce today's fabulous speaker. Dr. Michelle Odden is an Associate Professor of Epidemiology in the Department of Epidemiology and Population Health at Stanford. And she's also a research scientist in the Geriatric Research, Education, and Clinical Center, or GREC, at the Palo Alto VA healthcare system. Her research, which is funded by the NIH, has two major foci. First, to better understand the biologic and physiologic mechanisms that characterize the aging process. And second, to improve our understanding of how aging affects preventive strategies for cardiovascular disease and other morbidity, including dementia and disability. And she also has a particular interest in populations who are underrepresented in research, including minoritized populations and frail older adults. And she is a fellow of GSA, and she chairs the Aging, Injury, Musculoskeletal, and Rheumatologic Disorders Study Section at NIH. And she also leads at Stanford the Justice, Equity, Diversity, and Inclusion Committee in her department, and strives to support an anti-racist and anti-oppressive academic culture. So I'm going to turn it over to Dr. Odden, and we look forward to your presentation.
Well, thank you so much for that wonderful introduction and for the invitation. I'm really delighted to be here today. I have no conflicts of interest, although I do receive funding from the National Institutes of Health. So I don't have to tell this group that the cardiovascular benefits of antihypertensives may not outweigh the potential harms in older adults. And this has led both patients and providers to become interested in deprescribing of antihypertensives. We've seen that antihypertensive deprescribing is common in the nursing home. One study found that nursing home residents with low blood pressure and a recent fall about 11% experienced drug de-intensification within 1 week of that index event. Another study found that among nursing home residents with limited life expectancy or advanced dementia, about a third were deprescribed over the next 30 days. Work from our group has shown that among long-term stay residents, 11 to 42% were deprescribed within 1 month after a potential triggering deprescribing event, including incident low blood pressure, a fall, electrolyte imbalance, or an acute renal event. You'll note, interestingly, that all of these studies were conducted within the VA nursing home, which is called the CLC, and I'll touch on later reasons why that might be. Recent deprescribing trials have shown no harm yet that's not true for older trials. So a Cochrane review of studies of withdrawal of antihypertensive medications found suggestive evidence of a greater risk of MI and stroke. Although it should be noted that the majority of these studies were were from about 50 years ago, so they were quite old, had short follow-up, and most were within a single center, which limits the generalizability as well as the relevance to current practice. Among the two recent trials of deprescribing, the Dante trial, which was about 400 adults, 75 and older with mild cognitive deficits, found antihypertensive deprescribing had no change on cognitive, psychological, and general daily function, as well as adverse events. And the optimized trial also showed no meaningful change in systolic blood pressure control or adverse events. So today I'd like to suggest that target trial emulation can help augment this growing evidence base. Briefly, what target trial emulation is a systematic way of analyzing observational data using the design principles of RCTs. It's a method to address many sources of bias common in observational data, and a powerful way to estimate treatment benefits and harms. There is an excellent methods investigation recently published in JAMA that found a Pearson correlation of 0.93 among 16 target trial emulations that replicated RCTs and had similar design as well as measurement measures. So I also want to note that TTE is not a magic bullet. So there are still issues of bias, primarily the bias due to non-randomization of treatment that we need to consider. It's also not easy, and it's not always feasible given the data that we have. So with this in mind, the outline of my talk today is as follows. First, I'd like to tell you a little bit more about my background and motivation for working in this area. Next, I'll tell you about the study design of our VA long-term care cohort. Then I'll provide a brief introduction to target trial emulation, and then share some results from our cohort. And I would like to ask that you do not share the results from our target trial emulation outside of this webinar, as most are under review right now, and I'll remind you of that later. So while I was a PhD student in Epi at UC Berkeley, I came across this review article from James Goodwin, which was really had a big influence on me. And many of you probably saw this paper and then the series of responses to it, but it was pretty thought-provoking. And you'll see that Dr. Goodwin starts off the abstract with the statement that the consequences of hypertension and its treatment differ in very old men and women compared to younger populations. Then at the very end of the article, he notes that there are many ways to define potential categories of very old individuals, such as age, walking speed, level of cognition, ejection fraction, level of affect, and self-rated health. So it was this paper that got me thinking about some of the paradoxical findings of hypertension in older adults, and also that age is not always the best way to measure the age that's meaningful in older adults, and to think about other dimensions of health status that might better represent biological or physiological age. My thinking on hypertension management deepened during my time as a postdoctoral fellow at UCSF and the San Francisco VA, where I had an opportunity to work with many clinicians who helped me to understand that the management of high blood pressure was not as straightforward as I had thought. Not only were the guidelines confusing, conflicting, and constantly changing, but my colleagues told me that the patients that they saw in their clinics often were not represented by those who were participating in clinical trials. So I began thinking further, like Dr. Goodwin had noted, about functional status as a marker of heterogeneity in aging. We all know that people of the same age might age quite differently. They could be like the couple on the left, aging well, able to stay physically active, cognitively intact, maybe even still working. Or they could be like the gentleman on the right, living in long-term care, having mobility difficulty, and perhaps cognitive impairment. So one of the measures I became really interested in is gait speed, because it's so easy to measure in the clinical and research setting. It's non-invasive, and it's a great integrative measure of functional status. So the first paper in this area, which I wrote over 10 years ago, looked at gait speed as a stratifier of older adults in NHANES. And among these older adults, we looked at the relationship between high blood pressure, here classified as systolic greater than 140, and mortality. And we saw among the faster walking older adults in NHANES a higher risk of mortality among those with higher blood pressure, much like you would see in younger adults. When we looked at the slower walkers, we saw this attenuate. And then when we looked at those who could not even complete the walk test, or those who were the most frail and the most functionally dependent, we saw the relationship was inverted. So this work served the foundation for my first R01 in the space, in which we looked at functional status as a stratifying variable for both blood pressure and treatment. And we found fairly consistently in observational studies that lower blood pressure was associated with a benefit among well-functioning older adults, but was associated with no benefit or even harms among poorly functioning older adults. We saw some evidence of effect modification of treatment, especially in the SHEP trial, and modest, although not clinically meaningful, evidence of effect modification in SPRINT. And so this work, I unfortunately don't have time to talk about today, but it was really the foundation for our current work, in which we've moved on to those older adults with the most functional dependence, those residing in nursing homes. Also, an inspiration for this work is the fact that in reviewing the evidence, none of the large RCTs, especially the placebo-controlled trials of antihypertensive medications, included nursing home residents. So really, we're extrapolating what we have learned from better functioning adults without cognitive impairment and lower levels of multimorbidity to those with disability, dementia, and multimorbidity. So to conduct this research, we have built a cohort of veterans residing in nursing homes, which the VA term for those is community living centers. So for the purposes of this presentation, I'll use the term long-term care, nursing home, and CLC interchangeably. So this was our next grant, which we were fortunate to get funded, although it took us 4 tries. So I'm sure everyone on this call also knows it can be difficult to get deprescribing work funded. But we were fortunate to get funded. We're just ending this grant where we were able to build a cohort of 45,000 veterans who've resided in long-term care settings for over the past 15 or so years. Okay, so I want to talk a little bit about some of the benefits of using the VA CLC as a setting for deprescribing research, which you'll see in this work and also the earlier studies that I referenced. So as you all know, the VA is a single payer healthcare system, so we're able to draw on data from multiple different care settings. Importantly, this allows us to knit together nursing home time and hospital time. So we see that a lot of residents' nursing home stays are interrupted by acute hospitalizations. And in the VA, it's quite straightforward to knit together these experiences. We also have barcode medication or BCMA data. So this means that we have medications administered, not just those prescribed or even filled. So unlike a lot of other pharmacoepi research, we're able to look at actual medications given, and we don't have to worry about adherence. Also, a strength of the VA CLC is that we have data on vitals. So data on vitals, specifically blood pressure, is critical for deprescribing work on antihypertensives, and vitals are not available in CMS data. Although we do have access to CMS linked data among VA CLC residents, We haven't integrated that a lot in this first grant, although we're working on integrating it for some upcoming work. Limitations, of course, this population is a unique long-term care population, right? So we know that the non-VA long-term care population is mostly women. The VA long-term care population is predominantly men. Also, the comorbidity of this population doesn't represent the non-VA population. So this is going to affect some of our prevalence estimates, but I would argue that most likely it won't affect the balance of benefits and harms of deprescribing, although I'm happy to discuss this more at the end of this session. Okay, so we started off by doing some descriptive work in this cohort. So I'm going to present some of that first before diving into the target trial emulation. So this is a paper we published in JAGS in 2022, looking at trends on blood pressure diagnosis, treatment, and control among VA nursing home residents. So the x-axis here is fiscal year, and the y-axis is the proportion, and this is people with blood pressure control. So you can see that veterans residing in CLCs had very well-controlled blood pressure. If we use the threshold of 140/90, over 80% had their blood pressure controlled. If we use the ACP/AFP threshold of 150/90, it was almost all veterans had blood pressure below those levels. There seemed to be a significant, although modest, temporal trend of slightly less intensive blood pressure control over time. You can see that overall adherence with guideline concordant blood pressure remained fairly high, but a benefit was that we saw the prevalence of very low blood pressure, less than 90/60, was quite a bit lower, about half over time. So this seemed like a promising trend. In looking at factors associated with antihypertensive treatment, we found that age, Hispanic ethnicity, cancer, and dementia were all associated with lower likelihood of being on treatment, whereas Black race, diabetes, renal disease, stroke, heart failure, and MI were all associated with a higher likelihood of being on treatment. In looking at control, age, Black race, Hispanic ethnicity, diabetes, renal disease, stroke, and cancer were all associated with a lower likelihood of having blood pressure controlled to less than 140/90, whereas heart failure and MI were all associated with a greater likelihood of having blood pressure controlled. Another paper that one of our co-investigators, Laura Graham, led, really interesting work looking at the week-to-week blood pressure variability in the last 6 months of life. So she looked back in the period prior to death, and she found that systolic blood pressure decreases gradually, and then more dramatically 4.4 millimeters mercury in the last month of life. Interestingly, in our cohort, we saw diastolic blood pressure remained relatively stable. And week-to-week variability was stable, although increased about 30% in the last month of life. Laura looked at factors that influence that variability, and it appeared that most of this variability was attributable to increased complexity of care during this last month of life, such as hospitalizations, medication changes, and hospice care. We published another paper on deprescribing. We found that this is a descriptive work on deprescribing. As I mentioned earlier, we found deprescribing was really common in this cohort. We use the definition of deprescribing of a reduction in the number of antihypertensives for a 30% or greater reduction in dose maintained for 2 weeks. And I'll touch on that definition a little bit more later. But using this definition, so a sustained change for 2 weeks, we found the rate was 3.5 per 100 person weeks, or about a little less than 2 changes per year, 2 deprescribings per year. And we found that over 70% experienced a deprescribing, event at some point during their nursing home stay. although only about 50% had a net deprescribing. So there was a lot of changes, and some people went back up on their medications after a deprescribing event. In this figure, we looked at some potential triggering events for deprescribing, and we saw that the event most strongly associated with deprescribing was a creatinine increase of 50%. Interestingly, falls were the least associated with deprescribing, but that was likely because falls were a fairly common event in this population. So let me take a pause here. I'm going to switch into the target trial emulation, which gets a little more dense. So let me take a pause now and see if there are any questions or comments that folks have.
And again, you can put in questions into Q&A or chat. Nothing.
Nothing so far. Okay, well, everyone take a swig of coffee or a deep breath, get some oxygen going, because I'm going to dive into the target trial emulation. Okay, so our the next set of work that I'm going to describe is using the target trial emulation. But before I dive into this, I want to give you a little bit of background on what this means. So when you conduct an emulated trial of deprescribing, the idea is to outline a protocol, much like you would if you were to design a randomized controlled trial. So here you can see that we've specified 6 protocol components. Some are more complex than others, but just to run through them, you would start with the eligibility criteria, then the treatment strategies. So again, for treatment strategies, we looked at a reduction in the number of antihypertensives or a 30% or greater reduction in dose maintained for 2 weeks versus no change or increase. Then the assignment procedure, ideally we would have randomization, but of course we're not able to do that with observational data. So we pseudo-randomize through statistical adjustment. Then you specify a follow-up period, which could be 2 years or variable. I'm going to present some data on a study that we did looking at hospitalization for MI or stroke, although we also looked at other outcomes. And then the analysis plan. So ideally, you would pre-specify the analysis plan. That may not always be feasible as you get into the data, but that would be a goal. Okay, so let me talk through some of the more complex features. So you could see our eligibility criteria. We had several different criteria for being in our study, in our target trial. And I'll say we had some other criteria that were related to data availability, which I didn't list here. But less than 65 years at admission, had a CLC stay less than 90 days, or that was sorry, this should be a exclusion criteria, not eligibility. Sorry for that typo. So these were exclusion criteria. So less than 65 years, had a short stay, and that was intended to exclude those undergoing post-acute rehab, which is relatively common in the VA. We had to exclude those with an acute hospital stay lasting greater than 30 days during their CLC stay, but that was only about 14. Among those with stays less than 30 days, again, we knit that time together. So we pulled their BCMA data, their vitals, everything from their hospital stay and linked it together with their nursing home stay data. For the deprescribing work, we excluded those not on antihypertensive medications at admission because the benefit of deprescribing might be unclear, or there could be other confounding reasons. Among those with a history of heart failure or metastatic cancer, we excluded those folks, and then we excluded those with fairly high systolic blood pressure at the time of deprescribing. So one thing I want to focus on here is our decision to exclude those with short CLC stays. So this was done because we were primarily interested in a long-term care population, but it ended up adding to the sort of the challenge of our work because in target trial emulation, you would not want to have a situation like this where your cohort or treatment definition requires participants to survive X amount of time. So that can induce what's called immortal time bias. And just to give you an extreme example that I think really illustrates this, the problem of doing something like this, is that if everyone was deprescribed in the first month and then died, our deprescribing estimates would look more beneficial than they truly are, right? So this is a problem in target trial emulation research whenever you define your cohort or the treatment based on time. So a lot of pharmacoepi studies will look at, let's say, statin use for a year or 2 years. And the problem again is that requires that user to survive that long. So if the treatment is really risky early on, it can make the treatment look more protective than it truly is. So our solution to this was to start entry into our hypothetical target trial after 90 days, because then everybody would survive 90 days, or that would just be like the rolling start time of this trial. There are other ways in target trial emulation to deal with this, including cloning, but they can significantly increase the complexity of the design and analysis. But again, happy to chat about that more in the discussion. Okay, so after 90 days, we took the eligible residents in our observational study, and then we observed who met our definition of deprescribing and who did not, right? So each week, we divided our cohort into those who deprescribe and those who do not. And then we did that the following week. So we had like a rolling, what they call time zero in target trial speak, or baseline for our hypothetical trial. And the idea of doing this is that you allow for an increased sample size of your deprescribing group. So you're just allowing for repeated opportunities to enroll in the trial. And we did this for 12 weeks. And of course, the challenge is that who goes on to deprescribe and who has no change or an increase is not random. So there's a lot of confounding. And so to address this, we use statistical adjustment. We used a bunch of different approaches, but one that I would recommend in this setting is targeted maximum likelihood estimation, or any kind of what we call double robust method. And all this means when I say double robust or targeted maximum likelihood is we're basically fitting two models to control for confounding. You're fitting a model of your outcome. So, a survival model of mortality, or whatever your outcome of interest is, MI, stroke. And then you're fitting also like a model of your treatment, or propensity score type model. And it gives you, again, two opportunities to adjust for confounding. That's the double in the double robust. And it's been shown to be better at controlling for confounding bias than traditional multivariable adjustment. We also integrated some machine learning methods to fit these models. We used superlearner, which is what's called a stacked ensemble machine learning approach. And all that means is it's using a bunch of different algorithms and then choosing among them to fit the best model of both your outcome and your treatment. And the idea there is that you're able to use a more flexible modeling approach that might better fit the confounding structure than just your pre-specified, linear model. So we have spent a lot of time and energy using the best available statistical methods and tools to try to account for confounding. But I do want to be really clear with you, it's not magic. We can't control for what we can't measure. And so, unmeasured or residual confounding always remains a concern with target trial emulation. Okay, so the analysis plan, one thing that you'll need to choose in your analysis plan is whether or not you're trying to emulate an ITT or a per protocol design. And I have gone back and forth as to what I think is the best estimate for this work. And it's been really helpful to talk with both Mike Steinman and Say Lee about this because they've helped me to understand that ITT is really representing this clinical decision point where the provider would need to decide whether or not to deprescribe a patient without regard to what might happen in the future. A benefit also to the ITT estimates is that when you are emulating ITT, you're really only worried about baseline confounding, right? You're not worried about what happens during follow-up or whether or not people adhere to their treatment assignment. You're really only looking at that time zero. And again, like what happens here where people go into the deprescribing or no change group and controlling for confounding at this point. On the other hand, if you were to try to estimate the per protocol, you can better account for changes in treatment after your initial assignment. And if you recall, I mentioned that we had a lot of changes after the initial deprescribing event. And so in the real world, treatment is complex. So perhaps that would be an estimate that would be more meaningful to you. And I will say that in that JAMA paper and some other work that's been done, it does seem that the per protocol target trial estimates tend to better approximate ITT in trials. And let me just explain kind of intuitively why that might be. So we know that in trials, people are much more adherent to whatever treatment strategy they're assigned than in the real world. So if you're really trying to emulate a trial, in the real world, you're never going to see adherence rates that are close to what you might be able to achieve in a trial. And so by adjusting for that statistically through per protocol estimation in a TTE, again, empirically in the studies where they've had a trial to compare to, it seems like the per protocol estimates better approximate ITT in a trial. But of course, in this setting, we don't necessarily have a trial that we're exactly trying to emulate. So it's hard to know what the truth is. Okay, so let me go ahead and share some results. And again, I ask you to please keep these results to this group. Okay, so my PhD student, Xiaozhen Liu, did a really amazing target trial emulation of deprescribing antihypertensive medication and changes in ADL, which were obtained from the MDS from the VA CLC residents. So let me orient you to this plot. So on the x-axis is time in months. Then on the y-axis is ADLs. And I want you to pay attention to the numbers on the y-axis. So the ADL score in the MDS goes from 0 to 28. So what I'm showing you here is really zoomed in and not clinically meaningful changes at all. But we saw slight, because we had a large sample size, we were able to see small statistical differences. But again, I want to be clear, they're not clinically meaningful. But we saw the deprescribed group started off with a little bit higher ADLs, so worse function, and their function actually slightly improved over time, whereas the stable user group started off a little bit lower and then had worsening function over time. I also want to point out our median length of stay in this population was still pretty short, about 6 months or so. So that what you're seeing out here is really extrapolation and wasn't observed in a lot of our data. So in our study, we see, again, the deprescribing population had a little worse function and then attenuated their worsening compared to the stable user group, which had better function and then slightly worsened over time. Another member of the team, Bochang Jing, who's a statistician at the San Francisco VA, did some amazing work looking at cognitive decline. Here we use the cognitive function scale, also from the MDS. And let me orient you to this figure. So on the left is stable user, on the right is deprescribing. And I just want you to focus to start on the blue. So on the x-axis is time, on the y-axis is the predicted probability, and this is from a fully adjusted model. So the blue is cognitively intact folks, and you can see among stable users, the proportion cognitively intact declined a little bit over time. And the deprescribing group started off a little lower, but declined at, or I would say the proportion cognitively intact decreased at a slower rate. So again, this was statistically significantly different, but probably not clinically meaningful. Similarly, if we look at the other extreme, the severely impaired group, in the stable user group, we see that the proportion increased over time in this severely impaired group. And the deprescribing group started off a little bit worse, but the slope was less steep, right? So we're seeing them increase less. So similar to the ADL findings, we saw, again, that deprescribing slightly slows cognitive decline, although the differences weren't clinically meaningful. Some other work we have ongoing, or actually under review, looking at the risk of CVD. So this is an outcome that hasn't been able to be studied with a lot of precision in a lot of trials because it's less common, and the trials have been often short. So when we looked at an unadjusted target trial emulation of deprescribing and the risk of hospitalization for MI or stroke, we saw an estimate, not surprisingly, in the harmful direction, although not statistically significant. And then we saw that attenuate when we applied our full adjustment. And I put adjusted, but I'm really meaning we did a double robust method to account for this. And these are per protocol estimates, so they are adjusted for not staying in the deprescribing group. We saw a similar pattern when we used an expanded outcome definition. So again, folks who deprescribed in unadjusted analyses had a higher risk of hospitalization for MI or stroke, probably because they were less healthy. But that fully attenuated once we used our full statistical adjustment. We also looked at UTI as a negative control outcome. We would not expect UTI to be associated with deprescribing at all. But we saw, again, a similar estimate in the harmful direction and unadjusted analyses. So again, showing that perhaps sicker people are more likely to deprescribe. But when we did our full statistical adjustment, we saw that association completely attenuate to the null. So the use of a negative control is often done in pharmacoepi studies when you're concerned about residual confounding. So that was reassuring. Chintan Dave at Rutgers has a great paper that's in press in JAMA Internal Medicine looking at antihypertensive medication initiation. We did see folks initiate antihypertensive medication in the VA CLC. And he saw that the short-term risk of fall-related events was elevated, whether or not we looked at fractures, severe falls, syncope, or a broad outcome definition. He saw an elevated risk of fall-related events among nursing home residents initiating a new antihypertensive medication. Okay, so to summarize, target trial emulation remains the best available approach when trials are unavailable, or I would say to complement trial evidence. So one thing that we have to remember is trials remain strongly affected by selection. There's some great work by Tim Anderson and others looking at the proportion of adults who would be indicated a new blood pressure medication based on the ACC/AHA guideline. And Tim found that only about a third of those indicated a new drug would meet trial inclusion criteria for the trials that informed the ACC/AHA guideline. So, we're often taught in epi that randomized controlled trials remain the gold standard for causal inference. And I would push back on that, especially in an older adult population, and say that they offer one advantage, which is randomization. But, the selection of trials is immense, even with really thoughtful investigators who are geriatricians, which we saw in Sprint, that, there was some tremendous geriatricians supporting the design of Sprint. And I know there was a big effort to include older adults, but we still saw Sprint represent a selected population. So I would argue that TTA is a complementary approach to trials. Our work suggests that deprescribing is associated with no CVD harm and may provide a small benefit on function. New antihypertensive medications are associated with an elevated risk of fall-related injuries and outcomes. But of course, unmeasured and residual confounding still keeps me up at night. It's something I'm most concerned about in some ongoing work we're doing looking at mortality, because of course, proximity to end of life is associated with deprescribing. So looking at the causal effect of deprescribing on death is challenging. So we're looking at some new methods, which I don't have time to get into today, but that leverage essentially an instrumental variable approach, which can better account for unmeasured confounding. And again, happy to talk about that afterwards if anyone's interested. I'm really delighted to share that we received a good score on an R1, which is now pending to renew this grant and extend our work to study deprescribing of aspirin and other antiplatelet agents, as well as statins and anticoagulants in the VA CLC. So I really want to acknowledge that this is such a team effort. We meet monthly, weekly with the analysis team and monthly with the full team. And all of these folks are critical to the success of this work. And I would also welcome anyone to collaborate with us. My email addresses are here. So thank you so much.
Thanks, Dr. Odden. Really great presentation. Please now take this chance to put your questions into the Q&A or chat at the bottoms of your screens. And we'll see. It looks like we do have something coming in. Oh, from Bocheng Jing. So would you plan to conduct a large-scale, nationally representative clinical trial for the VA nursing home to, determine cause and effect officially or definitively on deprescribing? And if so, when would you, want to implement such a trial?
Yeah, I think we're ready. I mean, so yeah, let's do it, Bocheng, and folks on this call. I will say I'm not a trialist, so I don't pretend to be a trialist. Really my expertise is in observational data. And so I would say I'm not the person to lead that, but I think the time is ready. And I do think the trial will still have all the challenges of any trial, which means that selection will probably be an issue. But I think we could benefit from that. And I know folks are interested in that. So yeah, I think the time is now.
Great. And we have, okay, go ahead.
Oh, I was just going to say, I see a chat from Jinjiao Wang. So you may have already talked about this, but what are the differences between trial simulation and traditional approaches of observational analysis, such as propensity score matching? Is it the use of machine learning to find? Yeah, great question. So I would say that target trial emulation is just a little bit more formalization of what I would consider good study design in observational epi. So there's nothing magic that makes it target trial emulation. I do think there's some terminology that's been refined, like this idea of thinking a lot about what baseline is, which is called time zero in target trial emulation, and the role that could have on bias, specifically this immortal time bias. The use of cloning is pretty specific to target trial emulation. So there are some kind of nuances that I've seen develop over the past 10 to 20 years, but it's not like it's a different thing. I would say it's just a very well done pharmacoepi analysis. And you don't need to use double robust to be target trial. I would just say in this case or machine learning, it's just in this case where I'm so concerned about residual confounding, we wanted to throw like everything we could at it to see if it made a difference. And to be honest, it didn't make a huge difference like this, stacked ensemble machine learning method. Okay, so I see a comment from Gabrielle Schiller. How would we provide pushback to people who say that RCTs are the gold standard? And also if the large barrier is a hesitancy of including older adults in trials, or is it the difficult presented by recruiting? Okay, so the pushback, it's hard because in our, and I'm guilty of this, in like intro to epi, it's much easier to teach that RCTs are the gold standard for causal inference because of randomization than to really go into all of the nuances. I would say I do teach probably different than some folks who teach epi methods, because I try to always present it kind of as not as the pyramid of evidence, but as like all of these studies have different strengths and limitations. So I don't know, I'm beating my drum. I know, others like Tim are doing great work that help me beat my drum, but just to say that selection's an issue, but I don't know how to push back other than to keep shouting it. And then as far as a barrier, I think it's the latter. Again, I'm not a trialist, but I think it's more the difficulty of recruiting older adults and the logistical challenges of doing work in a nursing home where, these providers already have so much going on. That is the larger barrier rather than the hesitancy from the older adults themselves. I've also heard anecdotally a lot of concern from family members about, folks residing in a nursing home being overburdened, more so than the older adults themselves. But the clinicians on this call are way better to ask that question too. And a comment from Colleen, thank you for making the effort to study, now it fell off my screen, the frail older adults. Thank you, Colleen, for your comment. Okay, and then a question, I have a question regarding the TML approach for the treatment model. You mentioned the IPW approach. Could you elaborate a bit on the outcome model? May I ask what outcome model you used? Yeah, for the change in ADL and the cognitive function change, we used mixed models. So it was a linear model for the ADL, like a random effects model, and then multinomial logistic random effects model for the cognitive function data. And Bo Chang's, I see he's on the call, so he can correct me if I'm wrong. And then for the time to event, we just used a Cox model. Okay, and then another comment, let me actually jump over to the Q&A and then I'll jump back to the chat. So from Rajneesh Kaur, I'm sorry if I'm saying that wrong. Do you think your work might encourage pharmacists to make alternative hypertensive drugs where there is an easier way back from? Oh, interesting. You mean like to make drug choices, or do you think your work might encourage pharmacists to make alternative hypertensive drugs where there is an easier way back from, or easier way back from anticoagulants? I am not sure. I am probably, and I'm not sure if you mean to prescribe different drugs or to develop new drugs. So I'm not sure. I think maybe less drugs would be a better approach than different drugs. But feel free to follow up if I'm answering the wrong question. And then Sonia Sanchez Mendoza. Yeah, I'm so sorry, Sonia, I misspoke. So the people less than 65 years were excluded, not included. So all of our target trial emulation was in adults 65 and older. I apologize, there was a typo. But yeah, so this is only in older adults. And our goal there was, we were really interested in a population in whom deprescribing might be indicated. And because VA has a lot of short-term rehab patients, we wanted to increase the likelihood that we were excluding those folks. We weren't really interested in folks rehabbing because they would likely have a longer life expectancy and the benefits could outweigh the harms in those folks. So it was 65 and older were included. Okay, and then
Doing great.
let me jump back to Jin Wang. How was deprescribing identified in the EMR? Is it from the changes in the dosage, the distribution record, or provider notes? Yeah, so we had BCMA data, which is barcode medication administration data. So it's like when you're in the hospital, when they give you a medication and they scan it. So we actually, that's what's done in the CLC or the VA nursing home. So we actually knew when a provider had administered the medication. And the medication is barcoded, so we know exactly what drug they're getting, the dose, and the route of administration. So we're really lucky in this setting. It's like an acute hospital stay data where we have actual medication administered by a provider. We haven't looked at why medication changes were made, other than to look at precipitating events. So in our next grant, Laura Graham, who I mentioned, who did that cool paper on variability, has done some natural language processing work, NLP work, which is pulling off the provider notes and then using machine learning to look through them. So we're hoping to do some of that work to augment our study on potential reasons for deprescribing. So we haven't looked really at provider notes at all yet, but that's something that we hope to do for this next upcoming grant. Thank you so much all for the interest. Okay, did I miss anything? Oh, I'm happy to. Thanks for the great questions.
We have a few more minutes if people have questions. One thing that I wanted to just clarify is you presented some interesting data about triggers earlier. Were there any triggers required in your target trial? And if not, why not? It might be interesting that might help with some of the selection. I'm not sure.
Yeah, I think we did not require any triggers other than the exclusion of not having very high blood pressure. So our rationale, which I'll take responsibility for any poor thinking here, was that we wanted to be inclusive as possible to estimate a wide variety of outcomes, and also, thinking that this long-term care population who's older and has a high amount of multimorbidity, cognitive impairment, and functional impairment might all be actually good candidates for deprescribing. And the effects of deprescribing, the reason for deprescribing shouldn't impact ideally the effects. But I also understand what you're saying about selection, and that could have produced a population in whom the deprescribing was more intentional and provider driven, and not just due to complicated care or poor health status. So the idea was to be generalizable, but I do see the drawbacks to it as well.
And by triggers, just for those who, we mean events that a clinician might, react to by, de-intensifying medication, such as a fall or renal changes in kidney function. Looks like we do have another question from Anonymous. Did you look at the impact of deprescribing on kidney function and hospital emergency room visits?
We haven't looked at kidney function yet, so we are looking for people to propose new papers if you would like to. And then hospital emergency visits, we've only looked at those for stroke and MI, and that was the work that I presented with the stroke and MI outcomes. Those were hospitalizations for stroke, or I should say with stroke or MI. So we haven't looked at ER visits, just the hospitalizations. So also an area for work.
Great. Well, a big thank you so much for presenting your work and for giving us a sneak preview. I guess just to reiterate, Dr. Odden has asked us not to share yet. It sounds like these will be forthcoming in the literature soon. Thank all of you for attending today's webinar and for your questions and discussion. It has been recorded. And that will be posted on the US Deprescribing Research Network website. And you will get an email with an evaluation survey, so please fill that out. As for our next event, it's a big one. On May 15th, we are having our annual in-person US Deprescribing Research Network meeting, again in person, and this is going to be in conjunction with the Society of General Internal Medicine's annual scientific meeting, and that's in Boston on May 15th. You don't have to attend SGIM or register for that in order to attend our meeting, but just so you know that they're adjacent. And thank you again, Dr. Odden and everybody else, and have a great rest of your day.
Thank you so much.